Welcome, everyone. We are going to get started. It's an action-packed hour. Again, we are going to talk about anesthetic equipment, and this is really going to be kind of a trivia game in that you guys are going to get a chance to evaluate an image or a video and actively engage in deciding what you think is wrong about it, and then we'll discuss it. Quick disclosures, I am an employee of Jurox Incorporated. As the Think Anesthesia content coordinator, I contribute to the educational platform Think Anesthesia, and I'm a relief anesthesia technician at IndyVet Emergency and Specialty Hospital here in Indianapolis, who's sponsoring and putting on this educational opportunity for you all. We are going to be using an interactive polling system. So unlike many lectures, get out your cell phones. This does tend to work better if you're watching this presentation on a PC of some sort and then participating on a cell phone. But don't worry, you can try to navigate back and forth on a phone. You are going to want to enter my chat room by typing to the phone number 22333. So that's the phone number. The message, Amanda Shelby, no spaces, not cap sensitive, 600. So again, the phone number is 22333. Amanda Shelby, 600 is the message. You will get a notification that you've been let into the chat room. And then when a slide populates with a question, you'll be able to just type in A, B, C, D, or E and send, and then it'll populate on the slide that you've participated in the poll. Again, the polls are all anonymous. I'm not going to be able to see who answered what, so no concerns there. But it just makes it a little more interactive and fun. Okay, so anesthetic risk does exist. And when we look at the potential of anesthetic risk within the veterinary as well as human market, there are the highest number of associated risks are associated with basically ignorance or mistakes that are performed with the anesthetic equipment, or at least avoidable risks are associated with that. And so there is value in knowing your equipment, and risk does exist. Veterinary medicine, we're not as great at risk or preventing anesthetic death as they are in humans. And as we work with species that we're less familiar with or that are smaller and harder to assess, it does make it more challenging to keep those patients alive. And you can see those rates there. So anesthetic risk is there. Fortunate if you've never lost a patient, but many of us have done anesthesia for years, that it's an inevitable acceptance of the job that we will lose some. And so, as we assumed, it is true that as you anesthetize higher risk patients, that more anesthetic risk is involved. And so all of those things are things that I think if you're doing anesthesia, you understand exist. There are ways to increase and decrease the odd ratios for morbidity and mortality, and this is just a simple list of those things. Again, if we are able to be informed about our drugs that we're using and we select more dependable routes of administration, things like that can reduce risk. But again, if you're using xylazine, quite frequently, that's going to be associated with an increased risk, especially in cats. And then, of course, major versus minor procedures, urgency, all increases risk. And then, of course, if we're not familiar with the equipment or the medications in use or the species that we're anesthetizing, human error increases, and therefore the odd ratio increases. The beautiful things that we have control over that are associated with decreased risk is a dedicated trained anesthetist. So our goal and objective today is to really try to get you more comfortable with anesthetic equipment to minimize the risk of an anesthetic loss. Okay. Of course, monitoring heart rate and pulse rate, use of capnography and pulse oximetry, all greatly decreased risk in human papers, and that falls into the veterinary world as well. So those are all things that we can use to reduce our risk. Of course, we are all familiar with this quote, but it is tried and true that there are no safe anesthetic agents and there are no safe anesthetic procedures. There are only safe anesthetists. And so what that really is emphasizing is that we have to work hard to educate ourselves, to be good at recognizing problems as they occur. We have to be good at anticipating what problems could occur and being prepared to treat and prevent those. So I apologize, there's a response here. We were testing this before, but if you've entered the polling feature on your cellular device, the question I pose to you at this time is, do you currently use a checklist in your hospital? And so you can just simply type in A if it's yes, and press send, or B if you do not currently use a checklist, and press send. I'm just really curious who out there is using some form of checklist in their system. It can be very basic. Ooh, we got some people changing their minds. It can be very basic, and it can be quite involved. And I'm going to show you a checklist or the benefit of checklists. So I'm just going to pause for a moment and let people kind of enter. Again, if you're joining us, the phone number to enter this polling system is 22333, and the message that you will send to that number is Amanda Shelby 600, not cap sensitive, and all one word. It will send you a message that says you are now able to participate in polling, and from there you just type in an answer and press send, and it'll keep you engaged. Looks like we've settled down. I'm excited to see that 88% of us do use a checklist. Again, we're going to hopefully change some of your all's minds if you're an adamant no, we're not going to use a checklist, or we don't use checklists by the next few slides. So this is just a checklist that's used in human medicine. The reference there is at the bottom. I don't know why it's looking a little fuzzy on my end, but hopefully it looks clearer on your end. And before checklist, there was a certain number of deaths in the hospital. And then after the checklist, they reduced morbidity by a third, basically 36.5%, and mortality they reduced in half just by utilizing checklists, which means that we make human errors. We cannot avoid it, but we could minimize it just by implementing a checklist. Okay. Does this carry over to veterinary medicine? Absolutely it does. Ooh, we get to see the animations again. Yes, absolutely it does. The version on the left-hand side of the slide is a veterinary version checklist. It is focused more on surgical checklists. There are veterinary version anesthesia checklists. AVA produces one out of Europe that's free and available for download that you can search out. But this one was one that was tailored and made by a resident while she was at the University of Florida. And it did help catch errors like cutting the wrong leg, things like that. So they do exist. You can download them for free. The references are there, and you can quickly implement them. It takes less than 60 seconds to implement the veterinary checklist there, and it's quite comprehensive. Okay, so like I assume you are like me, that if we walk into a facility where we've never worked or we've never worked with their anesthetic equipment, you might be a little intimidated when you walk up to that anesthetic machine. But my hope is that over the next few slides, I can show you that no matter what anesthetic machine you're walking up to, any of these, you have the glorified, beautiful, I wish I could have every time on the left-hand side, that anesthetic workstation. And then you have a large animal machine. Then you have a somewhat skeleton version of an anesthetic machine. That's a matrix anesthetic machine from Midmark. And then you have this Vetamac workstation that's inserted on this cart on the far right. And so you hopefully, after seeing the next few slides, maybe not with 100% confidence, with more confidence though, could walk up to any of these machines and make them function. So the real important thing is to understand that while they may appear different visually, all of the parts and pieces that make them functional are similar. And so all you have to do is be able to recognize the parts, the fundamental parts and pieces of these anesthetic machines, identify them, have an understanding, just a brief understanding of what their purpose is to function properly, provide oxygen and inhalant if you're choosing to deliver it to your patient, and you can make any anesthetic machine function. So that's one of our goals. So just quickly, a review of a circle system. This would be a system that is theoretically designed to allow rebreathing of carbon dioxide should we choose to use a low enough oxygen flow rate. And for larger patients, we have an oxygen flow meter here. That's pretty simple to identify. Obviously, an oxygen source we would want to ensure is connected. This one is not set up to use an e-tank or a tank. It's set up to use a house line. Okay, we have a vaporizer that oxygen is going to either pass right through without picking up inhalant, or if our dial is on, right, that's the universal sign for increasing and decreasing a dial. If our dial is on, it will pick up inhalant at the precision percentage. And then we have our fresh gas inlet and outlet. That is where we're going to connect whatever breathing circuit we're going to use. If you're using a Mapleson circuit, so for small patients, you could connect it here bypassing the, let's see if the mouse works, bypassing this feature of the circle system. Okay, but this is going to be a circle system demonstration on this slide. Next, we have inspiratory and expiratory unidirectional valves. And the unidirectional word means that if these are functioning, when I inspire, when my patient takes a breath in, that tube or that channel is only going to be fresh gas. So oxygen and inhalant if the vaporizer is on. And when I expire, that tube is only going to be my expired gas. So when I breathe out, just let a breath out, it's only going to be expired gas. When these valves are functioning, we should have no rebreathing or minimal rebreathing of carbon dioxide if dead space is minimized. Because this circuit is made to use with lower oxygen flows, and you can facilitate a rebreathing opportunity for this patient, it's going to have a carbon dioxide absorbing material there that requires changing. Obviously, that's a very frequent source of leaks in our anesthetic machine because we open and close that, and dust and granules can get trapped in those seals. Okay, and then of course, the reservoir bag, if you're ever confused about where the reservoir bag goes, it generally hangs down. So I always look for a port that would hang down, and that's where a reservoir bag would go. And last but not least, the APL, or the adjustable pressure limiting valve, or pop-off valve, is in this system, and it is a twist valve at the top there. Okay. Oh, one last thing, the patient manometer. This is where we're going to observe if the dial can move negative. It'll move negative when the patient takes a breath, a spontaneous breath, and it will go positive when we squeeze that reservoir bag or provide positive pressure ventilation with a ventilator. Okay, so this is just a system pressure check. So this is a positive pressure check once we've connected a Y circle system and a reservoir bag that we're just using to ensure there's no leaks before anesthesia. And let's hope there's not sound. You never know what you're going to say in the videos. So this is one of my colleagues demonstrating pressure checking the anesthetic machine. I am someone who prefers to pressure check or pressurize the circuit with my oxygen flow meter. Part of this process is to ensure the integrity of all of the working parts and pieces of the anesthetic machine. And it's always my preference to use the oxygen flow meter, albeit it takes longer to pressurize that system. There, that pressure raised to a 20 or 30 centimeters of water as seen on that valve. And then after she holds it for 20 seconds, she is releasing that pressure by opening that pop-off valve. And to me, that's really important. You don't want to take your thumb off the patient end over here. You want to open your pop-off valve to release the pressure. Again, we are performing this to check all parts and pieces of this anesthetic machine for functionality as well as minimal leak to no leak. So I want to know that that pop-off is capable of opening and there's no holding excessive pressure. Okay, so when would you select one breathing system after the other? In a non-rebreathing circuit, we inappropriately identify the Mapleson circuits, but Mapleson circuits are all designed to be non-rebreathing circuits. They bypass those unidirectional valves, they bypass the soda-sorb canister, and so they're really dependent on high fresh gas flows to prevent rebreathing. So they are truly designed to be non-rebreathing circuits. We tend to gravitate towards small patients for that. Okay, Large patients, we tend to gravitate towards the circle or Y circuit that you can see here. I have two variations, the circle or Y, and then we have an F circuit here, which just is a coaxial tubing, meaning it's a tube inside of a tube. So the inner tubing is for the inspiratory line, and the outer tubing is the expiratory line by design. There are advantages and disadvantages to each breathing circuit. I personally am not a fan of non-rebreathing circuits and rarely, if ever, use them. But I understand what the advantages and disadvantages to using this circuit would be. So specifically, the advantages to using a circle or Y circuit, so the F circuit or the circle system, is that you can use low fresh gas flow rates. This helps reduce environmental waste, and the lower fresh gas flow rates reduce the amount of heat loss a patient experiences, because in veterinary medicine, our oxygen is not humidified or warmed and moisturized when it goes to the patient. And so we can actually see, in especially our small patients, a lot of heat loss from high fresh gas flow rates. Okay, some disadvantages, however, is that there is an increased work to breathing, and there is an increased amount of dead space. There's a way around that. If I want to minimize dead space, I can use pediatric tubing, which has smaller lumens. And if I'm worried about that increased work of breathing, I can give manual breaths, or I can monitor for hypoventilation with the use of a capnograph, things like that. And so knowing that allows me to feel more comfortable using this on small patients. As a means of math and examples, if we were going to use a flow rate of 10 milliliters per kilogram per minute for this 62 monstrosity of a dog here, who is absolutely squishable, you will see that performing that mathematics, 62 times 10 mils per kg per minute, would tell me that I could use a fresh gas flow rate with this system once maintenance anesthesia was achieved. So we allowed the patient to saturate with inhalant after induction at 0.6 to 0.7 liters per minute. So huge patient, low fresh gas flow rates we're capable of using on these systems. Compare that to your Mapleson circuits, which we traditionally call non-rebreathing circuits because they're only designed to be used as such. There are some advantages. One, the fresh gas flow rate is really high. That's required to minimize that chance of rebreathing of carbon dioxide. Advantages include less work of breathing, so they don't have to displace those valves or pull air back through that Sodasorb canister. And again, they are intended to be used as non-rebreathing circuits. Disadvantages, as mentioned, high fresh gas flow rates cause loss of body heat and do increase environmental waste for those of us that are environmentally cautious. So just to perform some math on this cat that's requiring some feline-friendly restraint, gotta love a good towel. At 200 milliliters per kilogram per minute, cat's 4.6 kilograms. If we did the math there, I could run my fresh gas, my oxygen flow rate at 800 or 0.8 liters per minute to achieve an effective oxygen flow rate for the system. So gone are the days where you just program 2 liters per minute in your mind. That is an unnecessarily high oxygen flow rate for maintenance anesthesia. And of course, just a very common misunderstanding, the fresh gas flow rate determines if the circuit is rebreathing or non-rebreathing, not the circuit in use. So again, on those circle systems, I can make them non-rebreathing circuits by using excessively high oxygen flow rates, and I will compromise my patient's body temperature and produce a higher degree of environmental waste. So it's just unnecessary to use high gas flow rates on those circuits. Okay, so this is just identifying the parts of a type of Mapleson circuit. This is a modified Bain system. It is my preferred Mapleson circuit if I'm going to use one, which again, I tend not to. If I have a really small patient, I might consider it, but I'm also weighing that against the risk of hypothermia in that patient as well. So I like this circuit because it has a true APL valve, or adjustable pressure limiting valve, so that twists shut just like a rebreathing or circle system. I like it because it has a patient manometer, so when I give a breath, I can see what size breath I'm giving to my patient. I'm not just watching the chest rise. And it has all of them have reservoir bags, but the reservoir bag with these other components allows it to be connected to a mechanical ventilator should I need assisted ventilation. And in my dynamic at IndieVet, we are doing some pretty critical patients. We don't do a lot of, we do a lot of routine scheduled surgeries, but like TPLOs, orthopedics, obviously being the bread and butter of any referral institution, specialty referral hospital, but we do a lot of emergencies. So thoracotomies, things like that, where mechanical ventilation is advantageous. This is me just quickly showing you how to connect a modified Bain circuit, my preference. I apologize if it's small on your screen. I should have zoomed in. So I'm connecting it up. It's a tediously long video, watching yourself. Connecting my reservoir bag. Again, it always hangs down. Closing my pop-off. Going to use my oxygen flow meter. Again, my preference to pressurize the system. I'm evaluating my oxygen flow meter for functionality when I do that. Of course, once I have everything connected, obviously I had a leak. I'm tightening everything up there. I turn off my oxygen flow, let it hold that pressure and release the pressure by opening that pop-off valve. At the end there, I was just connecting that capnograph. Last but not least, as you're selecting your breathing circuit, we do need to perform a reservoir bag selection. This is a formula that you can use to determine what reservoir bag you would use. I have the two extreme sized patients there for you. It's always advantageous to use a slightly larger size than a smaller size when you're calculating this. So for that cat, I would absolutely use a 1/2 liter reservoir bag. If you didn't have a 1/2 liter, a 1 liter would be fine. If you get excessively large, it's going to be hard to see them take good breaths because just their little tidal volume is a small percentage of that volume of the reservoir bag. On that big dog, I absolutely would round up to a 4 or 5 liter bag. I would not use a 3 liter bag for that dog. There are rates or ranges here. I personally do body weight in kilograms times 60. So I use 10 mils per kg as my tidal volume, and I multiply by a factor of 6. So weight times 60. You can use anywhere in this range and be fine. Okay. Let's test your knowledge. This is where we're really going to use that polling system. So I hope that that if you've entered the session with the polls, you're successfully participating. Again, it is all anonymous. I have no way to track your answer or know if you even participated. So don't be shy. Play along. It makes it a little more engaging. Again, the information will be at the top where you can access. You can either go to the website or you can text Amanda Shelby 600 to the phone number 22333. Some of these might have an E answer. So looking at this image, and I understand that if you've never worked with this anesthetic machine, you may not recognize all the things on here that are incorrect. And you should be able to identify 2 mistakes. Hopefully it works out. If not, we'll just play along and have a good time. Always makes me panic until the first one shows up, whether or not it's working. Nothing's more frustrating than when technology doesn't work. Don't worry, we're going to go through every scenario. Oh, the numbers are sitting still. There we go. Getting some movement. Okay, for the sake of time, because I think we have about 30 slides left, we'll just kind of give a pause for every session, and then when the numbers settle, we'll just move on. Don't feel bad if you didn't get to participate in actually entering the poll. Obviously, I'd love for you to participate, but in the sake of interest of time, we're just going to cruise along. So this is the exact same image. And the 2 correct answers were that the fresh gas outlet, and hopefully you can see my mouse when I get it over to that screen. It appears to me that the individual set up the modified Bain circuit with the interest of using this system, but they forgot to connect the fresh gas outlet. So if they connected this patient end to the patient's endotracheal tube, they're going to find out real quick that that patient is not getting oxygen or inhalants, because the oxygen and inhalant, when they turn it on, is going to be going into the room basically through the circle system. The other thing that is harder to appreciate unless you've worked with this anesthetic machine is that this scavenge hosing is curling around here and going into the back side of the pop-off on the circle system. And this is really dangerous. This could cause, I think I have some animations here, this could cause an overpressurization of the patient's lungs and barotrauma. So it could cause a tension pneumothorax and death if it was left unresolved. That backside of the pop-off is a one-way valve, and there would be no escape for expired gases. And so that could be a significant life-threatening risk. And I see that happen when we switch between rebreathing and non-rebreathing circuits all the time. So please be really conscientious of how you're setting up your scavenge tubing. So here's another one. The polls are going to be live as soon as the slide hits the screen. So you shouldn't have to keep retyping Amanda Shelby 600. Once you're accessed, if you can just type in A, B, C, D. Don't type in D. That should be a deleted answer, or E in this question. And just looking at that image. Everybody's in agreement, or we have a one person entering. Okay, well, since we're all in agreement, let's see what we've got. Again, same image there. So you guys were correct in that there is an absence, as I showed you on the incorrect attachment, there is an absence to the scavenge hosing. There's also something else that I'm a little upset about, and I find this quite frequently in hospital as well. And so I always like to take a moment to educate people on the proper use of an F air canister. So not only we don't have scavenge hosing attached. If we were to have scavenge hosing attached, I would still be upset because we would be going to an F air canister inappropriately placed on that anesthetic machine. And so if you can observe, that middle image has holes in the bottom. That F air canister is designed to allow gas to pass through it. So charcoal absorbs the halogenated gases, so the inhalants, right, that we're using, isoflurane, sevoflurane, desflurane, it absorbs them and allows oxygen, nitrogen, whatever else, air, medical air, whatever you're pushing through to pass through. If you're obstructing the bottom of that carbon dioxide absorber, or sorry, that F air canister, the charcoal absorber, you could overpressurize that patient's lungs. Now, lucky for us, that metal tray isn't a good seal, and while could overinflate the patient's lungs, usually it makes an obnoxious farting noise that alerts you to your F air canister being inappropriately placed. And anyone on the call that is from IndyVet who has heard this knows exactly what I'm talking about and probably chuckled. It also is inappropriate to turn it on the side. You could do that. It will still be somewhat functional, but it's not designed to maximally absorb. You're going to shorten the lifespan of your F air canister. I would rather see it turned on its side than sitting upright on a solid surface. You ideally would tape it to a pole or something, or have a nice little canister holder for it so that it is positioned properly. Of course, you do need to weigh these, and when they've gained whatever the manufacturer says, this manufacturer says 50 grams, they are to be disposed of and replaced. So they do take some maintenance. Okay, so here's two images. They are the identical machine. I just have a front image and a rear image of this anesthetic machine. See if you, now the ventilator is attached in this anesthetic machine situation. So if you're not familiar with how to use a ventilator, we can talk about it. And I don't know why D's missing. I'm concerned that my system's a little messed up. We might be missing the correct answer at some point. And we'll just give it a moment. I'm going to check the chat, make sure. Okay. Well, we are all in agreement that, oh, had a change of heart. Someone's being a smart. I almost said a bad word. It's recording, have to remember. Okay, well, looks like everybody feels that there's nothing wrong with this image, and that definitely could be a possibility, but I am going to show you something, again, that I find in practice that makes me a little concerned. Okay, so again, if you're not familiar with use of a ventilator, this is an MRI conditional anesthetic machine, meaning it can be used within in a relatively close proximity to an MRI unit, which we do have at NDVet. And this is just pulled right outside the room, the forbidden room where I couldn't take video and pictures through that wooden door there. And we do routinely mechanically ventilate our MRI patients. We're type A, we like to control them. So we like to ensure adequate ventilation, delivery of oxygen and inhalant when we're trying to monitor them remotely, which is fairly common with an MRI unit. So we usually start out, I actually like to start out just using the ventilator as my reservoir bag, the bellow as a reservoir bag, but most of the technicians or nurses I work with will start out on a reservoir bag and then convert over to a ventilator. And here someone has moved some of the tubing around. So they have the white tubing here replacing, this is now the reservoir bag, the inside of that bellow. Okay, but the scavenge hosing, if we look on the back, connects basically the dump valve or the spill valve of the ventilator back into the pop-off valve of the circle system. So this is similar to that initial image where we had a non-rebreathing circuit dumping back into the one-way spill valve there off the pop-off valve. And so this would eventually overpressurize and cause this ventilator to fail or alarm, fail to fire, and could overpressurize the lungs. So the correct answer for this is that the scavenge hosing, again, is inappropriately placed. And you're seeing a theme here that a lot of these mistakes result in barotrauma and overinflation of the lungs. And that's really what I want to bring your attention to, because that's probably the most dangerous situation that we can have there. Okay, so here's another image, and we're going to identify what is happened or happening in this situation. And I will say, in the creation of all of these videos or images, no patients were involved and no harm came to any patient. Okay, looks like things have settled. Ooh, people are changing their mind. Okay, so B was absolutely correct. That pop off is in closed position. Now, again, if you haven't worked with this anesthetic machine, you might not realize that it's screwed all the way down. But what really alerts us to that being a closed pop off valve is this high peak inspiratory pressure. That's what PIP stands for. So that high peak inspiratory pressure there, it's sitting at 30 centimeters of water. To know that it's 30 centimeters of water is insignificant. To know that the red is probably an alert of not good on that patient manometer. And if you observe that reservoir bag, it is extremely taut. And so the solution here is to relieve that pressure as quickly as possible. And I don't care how you get that done. If you are standing next to the patient's head, I would disconnect the breathing circuit from the endotracheal tube. Yes, I'm going to expose myself briefly to waste gas anesthetics, but I'm going to save that patient's life. If I was standing next to the reservoir bag where I had been giving breaths and I forgot to open the pop off, I might rip off the reservoir bag as the fastest means to relieve pressure. I can guarantee it will not be fastest to open that pop off valve. You will have to take several seconds of cranking that open. And so relieving pressure is the priority. I would encourage you, if you don't have these, this particular machine has, it's a matrix anesthetic machine. So Midmark makes it. They sell that picture on the bottom there. I will use the pointer for you. This temporary occlusion valve, they might have another fancy word for it, but basically that's what it is. You can replace your expiratory unidirectional valve casing with this built in between that and the pop-off valve. Basically, there's a button in there that you can just press and hold and squeeze the reservoir bag. And when you let go of that button, it opens that pop-off, so you're never having to crank it shut. And this is I think Surgivet sells them, Smiths Medical sells them. This is a little button valve, operates exactly the same way. It goes on the tubing where your scavenge hosing goes on the back side of the pop-off. And instead of turning that pop-off closed, you just press that button valve down and allows you to give a breath. This is a safety device that I'm a big fan of. Dr. Alan Cross designed it. He's a surgeon. He used to be at Blue Pearl in Atlanta. I don't know if he's still there. He designed it and commercialized this basically safety relief valve. And what it does is it's a preset valve. You can order them in 2 sizes. They're right around $100, $120 a piece. They go anywhere within the circuit. So here I have one on a Bain circuit, just stuck between the Bain block adapter and the breathing circuit. If it's a circle system, you can put it anywhere in that system. This one is I believe a 20 centimeter of water relief valve, meaning at 20 centimeters of water, if you left that pop off closed, it would relieve the pressure into the room versus over pressurizing the patient's lungs. They also come at 30 centimeters of water, which is probably the one I would gravitate towards purchasing. And some manufacturers offer you this high airway pressure alarm. It's really aggravating and annoying to hear, but that is indicating to you that there's high pressure. It unfortunately doesn't do anything about the high pressure, but it's an obnoxiously loud noise that when a preset high pressure is reached, it makes a noise and it alerts you that that's happening. And so again, like the other device, it just goes anywhere in the circuit. And when that pressure is hit, it triggers that noise and it alerts you to being able to resolve that quickly. Okay, so here's another image. Go ahead and give a shot. I don't know if this system works well with 2 answers. I believe usually in the format, I try to check allow 2 answers. See if you can recognize what's attached or not attached in this system. And this is also something that I find quite frequently in clinical practice when I'm navigating in and out of hospitals. Nice job, guys. Absolutely. Let's just go to where I can make the image a little larger for you. Yeah, so this is an F circuit. It's a coaxial tubing. The inspired tubing, it's actually a pediatric version in that it's green. That helps us identify it between that and a regular version, I don't know, adult version. So this is a coaxial circle system or F circuit. And the inspiratory line is intended to be the interior tubing, and the valve, the inspiratory valve, is on top on this anesthetic machine. And so someone just put this incorrectly. harm probably wouldn't come to the patient. Detrimental, it wouldn't be tremendously detrimental to the patient if you did this, but it's not going to be as efficient in its design for inspiration and expiration. You might have some rebreathing of carbon dioxide as well, excessive dead space. So excellent. Also, again, the scavenge hosing wasn't moved from what is the Bain block adapter over here. So it looks like we used a Bain block and we just didn't replace it in preparation for a larger patient. So great job. Here's another one. So what do you think's happening in this video? Let me play it for you. It might take over playing the whole slide when I play it. So you will just, oh, there's sound, goody. I don't know if sound is relative. I don't know if you can hear the sound because I have a headset on, but. Apologize for the shaky, the ventilator is alarming right now, if you cannot hear that. We had someone change their mind. Okay, so I'm just going to give you a moment. I could replay that if you would like. Just give everyone a moment. Go ahead and see if it plays. Oh, it won't play again. I apologize. It won't play again for you. Okay, great news is I have it on the next slide and it'll be a little larger. And I want to point out something that I'm emphasizing in this. Now, again, no live patient was on this ventilator when I created this situation. So here I'm giving breaths. If you observe the size breath that's being delivered right now, so how far the bellow drops with the peak inspiratory pressure that's being generated, so about 18 centimeters of water, 18, 20. And then if I come up here, showing you the size breath again, 200 mils. And that little light that's lighting up on the ventilator is showing that a high pressure is being achieved. Tidal volumes got a little smaller. And if you look at the associated peak inspiratory pressure, it's a lot higher. And so answer C is that it could be potentially having a pneumothorax is what we're experiencing here. So there's some reason for instant increase in resistance or compliancy in that patient. And so first thing you want to rule out is that we've overinflated a lung accidentally, or maybe we ruptured a bulla. Maybe this was a hit by car and it couldn't tolerate that size breath. And so that's the first thing that I want to rule out. For some reason, I'm generating excessive airway pressures, especially if I didn't touch or change anything on the ventilator, then something else changed. It could be that my surgeon's leaning really hard on the chest, and I might need to remind them that there's a little puppy under there or cat under there. Obviously, we are using large bellow, 200 mils, so probably a dog. And that they need to lighten up. So the answer was C, a patient experienced tension pneumo. The patient, if it was bucking the ventilator, that needle would move negative. Bucking the ventilator is taking a spontaneous breath. When a patient generates a spontaneous breath, it generates negative pressure and the needle would move the other direction. And maybe I had inappropriate ventilator settings for that patient, but they weren't unreasonable as far as the initial peak inspiratory pressure and assuming the patient was appropriate size for a 200 mil breath. Okay, so this is the same video. No, it's not. Okay. Apologize. We're not going to be able to do this one. The video is playing full screen, which is obstructed by the poll. How aggravating. Okay, so we'll skip that one. I will show you the video here, and you will not get to participate in the poll. Okay. So think to yourself, what is happening here? because I couldn't demonstrate the poll. I apologize. For you to be able to watch the video, we had to move forward. Eek! Okay, so this is a disconnection from the breathing circuit or a significant leak. You know, I have had a surgeon cut into the main stem bronchus once, and this happened, and they swear nothing was happening, and then my patient had to be disconnected, but then they started smelling sevoflurane, and I was like, yeah, it's coming from your end, my friend. That's a very rare occurrence, but if you're doing a lot of thoracotomies, you know, maybe that's a possibility. But this is something that happens, like maybe they're doing something on the head and they twist or turn the head for like a surgical mandibulectomy, something like that, and it just becomes disconnected. My capnograph might not show a change if the disconnection happens between the capnograph and the breathing circuit and not the capnograph and the endotracheal tube. And no, we don't want the video again. I thought I had a capnograph, but a significant leak, you would see a change in the capnography, or even a minor leak, you could see a change in the shape of the waveform of the capnography. Unfortunately, we don't have time to review thoroughly a capnograph waveform, but here's a follow-up one that does incorporate that in. So this is an example, this is an image of a patient monitor taken 5 to 10 minutes after a ketamine Valium induction, so a benzodiazepine and a dissociative agent, and the capnograph is showing this like TP shape form. And it looks like we are all in agreement. How often does that happen? Oh, look, it's a video. Very TP-like. So you guys are absolutely correct. This is an example that we've used agents that do not cause really good tracheal and laryngeal relaxation. So ketamine, we use Valium with it to help offset that. But when they've been placed on inhalant anesthetic and the inhalant anesthetic starts to saturate that patient, we do then see a relaxation of that and often a leak in the endotracheal tube. So again, we perform just leak tests of that endotracheal tube. This is a minimal occlusive volume technique, meaning the person's going to give a breath, listen for a leak, inflate the cuff. There are publications out there to show that this isn't the most effective means of properly inflating the endotracheal tube cuff, but it is the most practical because we can all do it, and we might not have those fancy cuff syringes that are for that. Okay, I'm curious, just because I want to know what you're doing out there, how do you inflate your endotracheal tube cuff? Do you use that feeling? Do you like put air in, I don't know, a syringe of air, a half syringe of air, whatever your system is, and just feel that balloon pilot to see if it's taut? Do you check using that minimum invasive occlusion technique where you're listening for a breath or leak and then inflating? Or do you use a specifically designed syringe or device to inflate the cuff? Just curiosity. This is for me, really, just to know what's happening out there. Very interesting. Very interesting. I'm surprised that many of you are doing C, but that is wonderful because there is evidence to suggest that using a syringe specifically designed to inflate the endotracheal tube cuff does ensure proper inflation to a higher degree, not 100%, but to a higher degree than the traditional MOV technique, which I'll be honest, a majority of us use, myself included. Okay, look at this image. This is one of my favorite images. I'm just going to let it sink in, and I'm going to let you think about what's happening here in this image. And when you're ready, type in an answer. It's so good. I think we can all agree the answer is not C. We got some mind changing happening. Majority wins. This is an oxygen float malfunction. Again, when we go back to how we pressure check anesthetic machines, my preference is always using my oxygen flow meter. I want to ensure my ball goes up and or float, the float goes up and the float goes down. It doesn't bob and jump around. If I set it at 2 liters, it stays there, it's spinning. You can see the oxygen house line. This machine does not have a hidden e-tank, is not connected. There is no oxygen on this machine, and that ball is stuck at, I don't know, 4 liters per minute. So it's time to replace that whole oxygen flow meter. So that was just a close up. This is an example of a malfunctioning oxygen flow meter. Here I'm just turning, nothing's happening. I'm getting frustrated back. Oh, something's happening. Look at it go. And then I'm like, finally, it's working. Wonderful. Oh, now it's not working. It's bobbing. That's frustrating. It's not spinning. The white dot isn't moving. So these are all malfunctioning valves. It does happen. The O-ring in that needle valve, so the part that you turn, does strip over time. And that jumping around, that big bounce, means there's a break in that O-ring. So this is something that your service company should be checking. If you see this, or if your flow meter drifts over time, you need to alert them when they come and have them replace that. It's not an expensive part, and honestly, you can learn how to do it in-house. So I'm just going to share the last 10 minutes and answer questions if we have any. Some parting tips and tricks. Just please label your F circuits. This is something that I find happens all the time. Mostly, I'm not going to lie, in the ER, maybe not because they don't know how to use them, more likely that they're dealing with something emergent like CPR super fast and they're applying it super quick. Having them labeled is just helpful to everyone. And if it is someone a little unsure of which part goes where, having them labeled resolves that. So I think that's just a friendly, nice thing to do. Some of them come labeled. If you ever have a ventilator failing to fire, so failing to deliver breaths, you could have low drive gas pressure. Most of us use oxygen to drive our ventilators. You could use other medical grade gases, but oxygen is most common. Again, that needs to be 45 to 55 PSI from your regulator. So yes, your oxygen flow meter will work with much lower PSI, but for your ventilator to dependably fire, you got to have this setting. So just keep in mind in that. If you are experiencing issues with your anesthetic machines, this is a commonly overlooked process to find small leaks in the negative pressure, the piping of your anesthetic cart. So if you're smelling little trace samples of gas and you can guarantee your breathing circuits aren't leaking on other machines, you just take I like a bulb syringe with a really small endotracheal tube connector and put it in my, your neonatal bulb syringe, little suction bulbs, and attach it, so deflate it and attach it to your fresh gas outlet. And it should not inflate. If it's pulling a lot of air into that ball and reinflating, that's telling me that there's leaks in your system. So there's leaks in the undercarriage, there's leaks in the tubing with that, and your machine really needs to be serviced. And even service professionals don't do a great job of performing this. So just every once in a while, it's worth doing a thorough review of your anesthetic equipment. Again, just to answer this question, all machines are created equal. While some are fancier than others, and we all have our favorites, and there are variations between machines, the parts and components are similar, are operationally similar. And if you just take a deep breath when you walk up to a new anesthetic machine and recognize the parts and pieces, you will be able to get any anesthetic machine to function safely. Closing slide. And at this point, I'm happy to take questions if you have any. I can see none are really submitted yet, but we'll just kind of hover here. I'm so happy that this ended on time because this lecture can go late with the polling options. So I believe the intent is that IndyVet will get this edited and positioned on their website for on-demand viewing, but I don't necessarily have a guarantee of when that will happen, just because, all good things take time.
Yes, thank you, Amanda, for that presentation.
Yeah. Happy to provide it.
We do have one question.
Yes.
What was the calculations for the rebreathing circuit oxygen flow rate?
So when you're wanting to use a rebreathing circuit, you can find various ranges. I'm just going to type it into the chat for you all. Let me change it to everybody. So rebreathing is the range I use, which you can find, again, a variety of ranges and reference manuals, but this is a pretty mid-range for most of the ones you'll find. 10 to 30 mils per kg per minute. I honestly usually calculate using 20 mils per kg per minute because for a non-rebreathing circuit, I use, the range is this. And I like 200 mils per kg per minute. So I just remember 20 mils per kg per minute for rebreathing or circle system, 200 mils per kg per minute for Mapleson or non-rebreathing. We use 40. Sure, use 40. It's more than you need, but absolutely, you can use 40. Now, I use those ranges for maintenance. So anytime I change my inhalant, like at induction or recovery, or if I feel my patient's getting light, then I do increase my oxygen flow rate, because the oxygen flow rate is what's going to change that concentration of inhalant in your patient as quickly as possible. Hi, Mary. By the way, hi, Mary. So yeah, 40 is absolutely fine. It's on the higher end. Yes, you don't need to use that high during maintenance, but it's not going to hurt to use that high. That's not excessively high, and it will not make it a non-rebreathing circuit at that flow rate. You have to bump it up to that 100, 150 to get there. I see another question from Miss Sarah. If the reservoir bag is filling up when hooked up to the patient and the pop-off valve is open, does that mean the scavenge system is set too high or too low? So if your reservoir bag is staying really inflated and you're not using a matrix or mid-mark anesthetic machine, they position their reservoir bag off the inspiratory line, which will always look a little inflated. It's the only machine I'm aware of that manufactures it that way. So if you're not using a matrix mid-mark anesthetic machine and your reservoir bag is filling up, I would be concerned that your scavenge system, especially if you're using what we call an active closed scavenge system, so if you plug into a wall, is not set high enough, so it's too low. That means the volume you're putting in is higher than the volume you're allowing out. So I would be very concerned that over time you might see an increase in pressure in that circuit and potentially cause an issue in your patient. So really watch your patient manometer on your anesthetic machine. It should be going down to 0 when that patient is in a state of expiration. So when they're not taking a breath. Okay. If it's not, then I would have your machine serviced. If it's creeping over 5 to 10 centimeters of water, then I would definitely stop using your machine. Okay, where can you get that vet surgical checklist? Let me type in the author, Thiemann. Hopefully I spelled her name correctly. Honestly, if you Google veterinary surgical checklist, it will come off. It was a clinician, it would come up, clinician brief article, and it's a downloadable PDF. You're welcome, Jerry. Excellent. All great questions. If you're in the Indianapolis area, I know Vetimac is a service provider for anesthetic machines. They do a pretty good job. Sarah's celebrating her thoughts on the machine. Right on, Sarah. Good job. There are other service providers that are nationwide as well. And if you're having an issue with the anesthetic machine, the first place I usually start, if you don't have a relationship established with a service provider, but please get one established and at least service your machines once a year, if not more frequent. At IndyVet, we service them like what, Mariah, every month to 2 months. Obviously, we're an emergency referral hospital. She comes by frequently. Let's say that.
She comes quarterly.
quarterly. So quarterly, and then she does come when we have issues outside of that. But we have obviously a lot of anesthetic machines, and we use them quite a bit. So at least get them serviced once a year. If you're using your anesthetic machines weekly, consider it twice a year. If you don't have a service provider, start by calling the manufacturer of your anesthetic machine. They have technical support people that can get on the phone with you. And if you're having an extreme issue and it is under warranty, sometimes they'll even send people out. I know Midmark has that service. You'll just have to contact other manufacturers to determine what your options are there, but get an anesthetic machine service company. What was the study reference for the efficacy of using a device versus it is, let's go back because I don't remember that one. I worked with Kelly Tiemann when she was implementing the surgical checklist at the University of Florida. So while I sounded smart, I really just had to do the clinical. I was one of the guinea pigs. So this study is, I don't know if you can see it on there. And so that's the author. And if you kind of just Google, I like Google Scholar. So if you go to Google and then go to Google Scholar and you type in that last name or that author's name and just ET2 syringe, I'm sure it will populate. So yeah, this was a relatively recent paper. It was kind of interesting to read. And those syringes are not that expensive. I don't, and you can use them for a long period of time. We've had one floating around IndyVet for a while, that True Cuff syringe, but the AG Cuff Fill brand, I believe I piloted it 10 years ago or so, but I haven't worked with it recently, so I can't comment on a preference for easeability or feasibility. So we're 8:01 team. So if there's no more questions.
There is one more.
Ooh, Dead Space. I love Dead Space. We just talked about this. Dead Space, very exciting. Dead Space is misunderstood. Dead space, anatomical dead space is the body. We're not going to talk about that. Mechanical dead space and such is anywhere expired and inspired gases commingle and mix. So tip of the nose to the start of the unidirectional tubing in a circle system. Okay, so anywhere inspired and expired gases mix, that's dead space. So if you do not shorten your endotracheal tubes, like in cats, they come standard, like, I don't know, 20 centimeters long, and you only intubate to, I don't know, 13 to 15 centimeters in a cat, that excessive amount outside of their nose is dead space. And you will see rebreathing of carbon dioxide with excessive dead space on both circuits. Dead space is not the physical tubes of the breathing circuit when the unidirectional valves are functioning, or when you're using appropriate fresh gas flow rates on a non-rebreathing circuit. So that's a great question. Love me a dead space conversation. Sorry, you should have asked that first. Okay, well, I don't want to take into your evening. My kids are wanting to get back on their iPads, I'm sure. Thank you everyone for joining. I hope you enjoyed the presentation.
Thank you, Amanda.
Thank you, Mariah. Farewell, everyone.
Bye.